Now back to Orthopedics on the Leading Edge, brought to you by Beaumont Hospitals on News Talk 760 WJR. Once again, here's John McCullough.
We're going to begin this program by talking to Dr. Paul Shapiro, who's an upper extremities specialist, and we're going to find out more about what it means to be that. What does that mean, Dr. Shapiro?
Upper extremity refers to the upper limb of the body, so that involves the shoulder, the elbow, wrist, and hand. So my practice is isolated to problems that involve those areas.
We've been hearing a lot as we talk to orthopedic people at Beaumont about sports-related injuries, pitching and that sort of thing, and the tremendous strain that throwing a curveball puts on the whole system of the arm. And do you get involved with any of that?
Sure, yeah. We see it all the time in all parts of the arm from the shoulder down. Shoulder injuries are very common with throwing athletes. The elbow can become very much a problem. Most commonly, we see things like tendonitis and tennis elbow or golfer's elbow. And then down all the way to the forearm and wrist, people get problems. And then certainly from injuries, from direct blows, and from contact sports, all these areas can be injured.
Now, our boss here, the big guy, Mike Feasey, had elbow surgery, golf-related, and it went so well, he's having the other one done.
Right.
He loves the game of golf. So I guess it's working.
Right. It's a difficult problem, and a lot of orthopedic surgeons don't like treating these problems because they're difficult to treat. So we try everything we can to avoid surgery with those problems. We do cortisone injections, we do stretching therapy exercises, and one of the newer things that we're doing for that is called platelet-rich plasma injections, where we draw the patient's blood in the office and spin it down and isolate the platelets, which are rich in the growth factors and healing factors, and we actually inject that instead of cortisone. So it's the patient's own blood, and the side effects, the negatives that happen with cortisone aren't there. And we're finding that the results are just as good, if not better, many times than cortisone. What
are some of the improvements that have been made, for example, in shoulder surgery? Because we hear people talk about it all the time, and they're afraid of it. They don't know what they're getting into, but you do have things that you do other than surgery before you actually get into surgery, don't you?
Right. Whenever we see a patient with a problem, we like to try and get them better without surgery. But when surgery is necessary, we've made some real big advances in shoulder surgery over the last 10 years, really. And really, I think that the biggest advances have been because the industry, the product industry, has become so open to listening to surgeons who tell them what they need to make it happen in the operating room. And these companies listened, and they came up with the products that we need to make it happen, specifically in arthroscopic surgery, where we can do surgery which is significantly less invasive than big incisions. So at this point, we're able to do just about everything in the shoulder arthroscopically through these little openings in the skin, and we watch it on a TV screen, and we can fix it.
That's amazing. Now, is there a shoulder replacement? Have you gotten that far yet?
Absolutely. The shoulder replacements have been around a long time. And that type of problem and that type of surgery is the one thing that we really can't do arthroscopically. And that actually requires incision, and we have to open the joint up and replace the surfaces of the joint.
Right. And by the way, if you'll excuse my ignorance when I ask these questions, because I really don't know, and that's why I'm so interested in doing this program, is because I'm finding out.
Right.
Now, the hand is an incredibly complex piece of equipment, I guess I'll call it. What goes on with hand research, and what do you do typically for people that come in like with a sore thumb that is giving them trouble?
Hand surgery is a wonderful thing. I love it. The anatomy is very intricate, and that, I think, is what made it so appealing to me. And there have been advances in the treatments, but specifically, I'm personally involved in some new research that we're doing for a very common problem that is often seen in women in their 40s and 50s, and that is arthritis at the base of the thumb. And the problem that we have is that surgically we don't have a real perfect option at this point. So this is an area of my research where we have a new idea that we've been doing for a year and a half now, where we actually take a cadaver meniscus from their knee. So this is a donor knee meniscus that we use, and we're using it to become a spacer in the joint where the two bones are now rubbing against each other without cartilage due to arthritis. And we're actually putting this piece of meniscus in as a cushion. And this is a research project that we're doing at Beaumont, and I've been doing it a year and a half, and fortunately the results are so far looking pretty good. We don't have long-term data, but we're following the data very specifically, and hopefully we'll see some good results in the long term.
And this is how advances are made in medicine, is through the research that the guys in the field do.
Right.
And gals, I should say.
It's the only way to do it. It has to be done correctly, though, so that the results are valid.
I know from somebody who told me that you're very active in resident training. Why do you do that?
Well, really, there are a lot of reasons, but I think that when you're teaching the residents, it forces you as a surgeon to keep yourself up on the newest advances and continually go back and read and relearn things so that when you're there teaching them, you can teach them correctly. Personally, on another note, I find it very rewarding to give back to these young students and surgery students who are very excited and eager to learn. Reminds me of when I was back learning in my training, and I have very fond memories, and I still keep in close contact with my mentors back in Cleveland. And there are two people in particular, but they're over at the Cleveland Clinic now, and they're wonderful people.
Well, you never really forget the mentor that may have changed things. Now, be honest with us. When you get the residents coming through, you try to sell them on upper extremity, right?
Well, it's kind of like your kids. You don't want to push them toward any specific career. You want them to feel it inside and feel it that that's what they want on their own, so that they have that own driven passion for it.
I'll bet you, though, that you can present things in such a way that it piques their interest and gets them to want to find out more.
I think you're right.
And as a resident yourself, that's probably how you got interested in what you got.
Absolutely.
Going. Dr. Paul Shapiro, is there anything you'd like to wrap up with that you'd like to say to the audience?
Well, I think I'm very fortunate to be at Beaumont. I think that the one great thing about Beaumont is that every aspect of our team is focused on excellence. And I think that combination of everybody striving toward that excellence makes for a great situation for people.
Everybody we've talked to has really gone along with that and supported that and actually promoted it. So I believe very, very strongly that that's going on over there. Thank you so much for being with us.
Thank you for having me.
Do you have a Beaumont doctor? Call the Beaumont Physician Referral Line at 800-633-7377 or visit Beaumont.Hospitals.com/leading edge. Orthopedics on the Leading Edge will continue on News Talk 760 WJR.